Okay, then we will move on to item number 4, which is the COVID-19 staff update. Okay, it looks like we have the dream team up here. Marilyn, are you going to be starting us off?
I will, thank you. Marilyn Mann, Health and Human Services. Good morning. Just so your board is aware, we did hear the public comment and hopefully will incorporate some information in this update. We did add 44 cases yesterday for over the weekend, bringing us to 1,051. No new deaths have been reported. And the good news is today we're probably likely to be adding less than 5 cases at the end of the day. We'll know more later, but we did have a little bit of a downtick. Hopefully that sustains, but at this point, you know, that could just be an anomaly. I guess the big news was that yesterday, first thing in the morning, the California Department of Public Health did issue a press release indicating that all the 4-week projections for ICU capacity in all regions throughout the state were projecting at a rate that allowed for the lifting of the regional stay-at-home order, and that included our Southern California region. The 4-week ICU capacity rate is you know, in a broad stroke, it's based on 4 factors: the current estimated regional ICU capacity that's available, and that's staffed beds, a measure of the current community transmission rates, and the current regional case rates, and the proportion of cases being admitted within that region. So, you know, all those factors are incorporated in the metric to determine that those 4-week projections. So the good news is that the regional stay-at-home order was lifted. That brought us back, as you are aware, we've been tracking in the purple with our case rates and positivity rates. So we did come out of the stay-at-home order in the purple tier, which, as a reminder, is the most restrictive tier because it's indicative of widespread COVID-19 presence. We will be, given our current rates, daily case rates and positivity rates, we are likely to be staying in this tier for a minimum of 3 weeks. And as a reminder, in order to move to the next lower tier, which is the red tier, we would need to be, for 2 weeks in a row, have a case positivity rate of between 4 to 7 per 100,000 people, which is about one a day for Inyo County based on our population, and a test positivity rate of less than 8%. And I think right now we're running about 16 to 17 a day case rate and a positivity rate of around 15%. I believe is what I saw most recently. So we have some work to do as far as continuing to, as a community, take all the prophylactic measures we can to ensure our individual safety and reduce risk of spreading the disease. I'm hoping that Anna can provide us a little bit of an overview of the vaccine update, and did want to let your board know that we are in the process of working with our Northern Inyo partner at Northern Inyo Hospital and Southern Inyo to streamline that registration process for the vaccinations. So we are going to be working on reconciling our registration and the waiting list, and moving very shortly to a one point of contact in which people will either be able to register directly online, and for those individuals who may have technology, a lack of technology access or capability, we'll be able to connect them with someone who can assist them in registering online. This will allow us to better ensure that those highest priorities are getting referred to a vaccination distribution point, and getting connected with an appointment as quickly as possible. And I say that understanding that we're in tier 1 of phase B, which is close to 8,000 people approximately. And we're getting distribution of weekly distributions as low as 100 vaccines a week, sometimes 300. So we're not getting a stable flow of vaccine coming in that we can do, a lot of penetration into that group. However, we are continuing to plan on and asking for vaccines and any redistributed vaccines. We are every week ordering our maximum amount, asking for additional, in hopes that we can somehow schedule a mass vaccination clinic sometime in February. Again, that will hinge on the availability of vaccines. And I'm going to take a breather there, and Anna, I'll turn it over to you as far as that broader vaccine update.
I'm sorry, let me just add one more point here. I think that's absolutely critical, that those are two separate issues. I think the key issue for at least my constituents and all the constituents that I've heard from has been the registration. If we all understand that the number of vaccines that we're getting is limited. But the coordination of the registration is absolutely essential for people's well-being, mentally and potentially physically. But just to get that where, well, you should call also. And then if you call Lone Pine, you might be able to get in Lone Pine. And then if you call LA, maybe you can get in Riverside. It just doesn't make any sense to me, and it confuses people. Comments that I'm getting. So if we can get that registration, the single registration figured out where you can coordinate it, I think that's going to solve, it's not going to solve the COVID problem, but it's certainly going to solve some mental problems that I know people are having right now.
Yes, and the rollout, relatively speaking, our rollout has gone very well, and we are learning from any errors and hopefully doing course correction that makes it as smooth and seamless as possible. I do want to alert your board that the state, the state could look at changing priorities. We just don't know, but we are planning based on what the state identifies as the priority categories, and as we're trying to be as nimble as possible, and actively get this vaccine distributed as quickly as possible, so that we are, we're really getting a protective layer in our community sooner than later. So, Anna?
Thank you. I'm sorry, Supervisor Griffiths, it looked like you wanted to say something.
Yeah, thank you. I was just wondering if you all are aware of the state's plan for one single application, an app that you can sign up on, and it's been piloted in San Diego and LA counties. And So that may be great, but to be honest, that also makes me really nervous because their technological solutions have not been so great lately. So are we planning for that, and will we be integrated into that?
Yes, I'll speak to that a little bit. I do want to back up just a little bit, and just to be clear on our numbers, and where we're at in the purple tier. Marilyn, I think I heard you say that our case rate is between 16 to 17 per day. I just want to clarify for the public, because you may see that reported a little bit differently. We are averaging about 16 to 17 cases per day. When that translates to a rate per 100,000, that's more like 90. Case rate of 90 when we translate out to that larger population, what actually gets posted on the state websites and what they're tracking. So I just want to provide that clarification that our case rate is very high right now, and that is based on that average that we've been seeing of about 17 cases a day. So we would need to get down to really more like five to 9 cases per week before we're really meeting those criteria to move into red tier. So we're significantly higher than that right now. I just want to clarify those numbers a little bit to give some context to where we're at from a tier perspective. On the vaccine front, we have been working very closely with our partners, and as Marilyn said, course correcting as we need to. So we do realize that having a streamlined and easy way for our public to get information as well as to register to be in line for the vaccine is important. So we're taking steps in that direction to consolidate our list and our registration process so that we can help have a one point of contact and then work very closely with those partners. Currently, the partners we're working with are both of the hospitals, Northern Inyo Hospital and Southern Inyo Hospital, as well as Vaughn's is getting up and ready to be able to distribute more vaccine as well. So we're working on, under the current guidance for how to prioritize those vaccines, making sure that we're consistent and having an easier way for the public to navigate that process. And then once we start getting more vaccine in, are poised to be able to get that out in mass, as Marilyn had stated. While we are using an internally developed form to be able to get that list going, as Supervisor Griffiths mentioned, the state has been working on a new program from the clinical perspective, especially in public health. This program is expected to be a little bit more nimble than the current scheduling program that we're using in the interim. So this is going to give us a little bit more functionality as we're rolling out vaccines specifically out of the public health department and how to or division, and how to schedule people and manage those vaccine clinics so that that's really an easier way to register. But it also has a consolidated function really at the statewide level that feeds down to the local level in getting people registered and prioritized within those guidelines. So we are expecting, now that the pilot is complete in some of the larger counties of California, we are going to be seeing a rollout schedule on Thursday from the state for this new program. We are being mindful of the fact that we may then need to reintegrate our list into that program if it looks like that's going to be helpful. I do think there will be some functionality that will be helpful for us at a local level, but we don't have a lot of detail about how the program works yet. We are expecting to see have a presentation on Thursday around what the functionality is, what it looks like from a registration list perspective, and then what the schedule for rolling that out statewide will be. So not a whole lot of information to share yet, but that will be coming down to us towards the end of the week, and I hope to have an update for you next week.
Excuse me, Anna, will we be able to do that ourselves as opposed to going back out to the public and saying, just kidding? You got to register again now. We got to
certainly that is our hope, and that's what we'll be looking for, and then gauging whether how functional that is. I honestly don't know from on the background what that system looks like and what it allows us to do yet, but absolutely, we've already put many people through this process of registering with us. We'd want to make sure that we have the capacity to upload that and not have people go through that process again.
And then just a follow-up question to that, with regard to what Nina was saying earlier, do we have the ability to, to sort of, start from 100 years old down, irrespective of the comorbidity issues, which should be put in there too. But I mean, can we do that? Can we go, oldest down to whatever young is, 65 right now or whatever? Can we do that so that we make sure that the most vulnerable age-wise?
Mm-hmm.
Again, I know there's comorbidity issues, and that's a very complicated thing. You got to, somebody that's 65 may have much more serious issues, or even younger than those. But
the short answer is yes. By consolidating, that helps us get make sure that we're all applying the same guidelines, and it helps us to kind of sort through and help with the prioritization around that. It also helps us pivot as we see our statewide vaccine advisory committee continually looking at these complex issues of how to prioritize and balancing the exposure through individuals who are working and providing certain types of essential services, as we saw in the first tier with our healthcare systems, making sure that we're protecting those that have high exposure risks, as well as protecting those and impacting those populations that tend to get sicker and even are more likely to die from this disease. And so being able to really have a consolidated way to prioritize those older and more vulnerable populations as well, while balancing the limited amount of vaccine, it does give us that capacity to do that a little bit better at the local level. And as those guidance, as the guidance may change over time, coming down from the state level, to make sure that we're all moving at the same pace and making those adjustments.
So Anna, can I ask a question? Can I just get some clarity on that? That Supervisor Pucci brought up the point that I hope to get a little more clarity on. Can you just, so to clarify, you have the ability outside of the tiers, or we have the ability outside of the tiers to reprioritize? Did I understand that correctly? Is that, no?
No, I'm sorry, let me clarify. So within the current tier, so we are continuing to serve 1A healthcare. There are still some of those filtering through, right? But moving into tier 1B, into 1B tier 1, sorry, get my terminology straight. That does have an age component to it. So anyone over the age of 65 is in that tier, as well as a couple of industries. So there is at this point in time an age component and a workplace exposure component. So I just mean within that group that we're currently focusing on, that it allows us to kind of balance and spread that out, so that with those providers that we have available, that we're able to kind of equitably spread out the vaccine to cover different categories within that tier, and certainly look for the highest, try to make decisions about highest risk in getting those done first.
Thank you. My other question is with regard, I've heard it a couple of times, I'm sorry, a couple of times with regards to Toyabe. Are we able to coordinate with them, or do they work? Are they really better off to function independently with their population? Is that correct? Or, because I hear them sometimes, but then other times I don't.
Yeah, so we are working closely with Toyabe, but their allocation of vaccine, because they're Indian Health Services and federally funded, they are getting an allocation separate from the county. So the allocation that's coming down to Inyo County and distributed does not necessarily go to Toyabe because they're getting a direct allocation, but they're generally following the same guidelines as far as focusing on. So really for in the beginning, one of our most vulnerable populations from that Toyabe serves is the dialysis patients, and so they really focus there and have been focusing on their elders. So they are following generally the same kind of guidelines for prioritizing the vaccine. We do hope, as Marilyn said, we are hoping to be able to set up some more mass vaccination clinics just from an efficiency perspective. Getting a whole bunch of people done at once is desirable to the extent that we have vaccine that allows us to do that. And so we do have, we haven't made specific plans yet, but Toyabe has indicated their interest in assisting with that as well. So as we get closer to that, we may be able to utilize some of our partner agencies in that way, in adding to the number of shot givers that are participating in a mass vaccination kind of scenario.
Do we know the numbers? Sorry, Jennifer, I didn't. Go ahead if you have.
Okay, real quick, and then I'll stop. So do we have the ability to, if we were to partner with Toyabe, and they have the dialysis staff members that are great with needles, but do we I heard yesterday or this weekend, I guess Nevada has also authorized everyone from phlebotomists to veterinary technicians to assist with a mass vaccination. Does California or Inyo County have something similar? Do we have that?
Yes, I would say at the statewide level, we're getting, there have been some allowances. So expanding the types of healthcare workers who don't traditionally provide, are able to give injections. Those have been either, we have some waivers in place to expand that, or new protocols in place to expand that. So we do have some focus at the state level in expanding the number of people who are able to give shots. At this point, as we're getting into our mass vaccination planning, at least in the beginning, we do feel like there are quite a few individuals who are interested in volunteering that have reached out to us, as well as our partner agencies, and being able to stand something up. I feel like at this point, we could staff that. On a long-term basis, if we did multiple mass vaccination clinics, we certainly will be looking at some of those non-traditional shot givers as needed.
Thank you very much.
Do we have an idea on the numbers of vaccines that have been given out through the Toyabe system?
I haven't had an update in the last week. I believe they got similar to what we've been seeing on a weekly basis, 100 here, 100 there. I don't know their total that's been administered at this point. I know for us, we're starting to see, I hope with some consistency, that we'll be getting at least 200 to 300. And I know Toyabe was waiting for more vaccine and hoping that their supplies were going to be increasing as well. Plus, they're spreading it over a larger jurisdictional area with both Inyo and Mono. So I will have to get an update from them on what their weekly allocation is looking like now.
Okay. Yeah, I appreciate that. I know that numbers are very important for the state, and they're working on trying to get that as quickly as possible updated. And, I want to make sure that our county numbers reflect all of the Toyabe numbers as well. And then I'll get to you, Dan, if your hand. One more question is, I think there's some confusion in the public about the intersection between Mono County and Inyo County. And, I've had some conversations with elected officials up there, and you can tell me if this is true, is that Northern Inyo Hospital, the rural health clinic, they will vaccinate existing patients, even if they live in Mono County. So if Tri-Valley people are getting their health care at the rural health clinic, then they can get vaccinated at the rural health clinic, which becomes problematic, or just not problematic, but, when you talk about the efficient distribution of doses between the two counties. But then I've also heard that Mono County will, under the sector categories, if people are working in Inyo County, they can get vaccinated in Mono County, even if they live in Bishop or live in Inyo County. And I don't know if that's true, but I guess my question or my request is that we have coordination between the two counties, just to make sure that is as seamless as possible. I don't think we want to get into, a competition of, ours first, yours, but make sure that we're working seamlessly together on that, because it would seem like mass clinics and stuff that, you know, at least coordination, if not sharing of resources, would be a really good idea.
Yes, I agree. We have been in contact with Mono County Public Health and have worked through a couple of those details. And I would say that, yes, for especially we saw in 1A, and we're continuing this through with 1B and continuing to revisit, because we don't want to send too many, we don't want to push too many Inyo County up to Mono or likewise Mono to Inyo. But especially in these border communities, we're on the same page that individuals who live in Inyo County but work in Mono and qualify for work would be covered. Those that live in Mono County and work in Inyo County or receive care in Inyo County would not be denied services. So we're not at this point where we're, you know, feeding vaccine back and forth, because it generally balances out, but it's definitely something that we're mindful of and watching, so that, you know, not only is there access for those kind of border areas, but that we're not weighting too heavily residents here going up there or residents up there coming down here. So I think that's something that in our weekly communications we'll continue to monitor. But ultimately, if we have people providing an important service to us in Inyo County and they live in Chalfont, it's important for us to make sure that, you know, if they meet the qualifications, they get vaccinated. And likewise, if we have a nurse that lives in Bishop and works at Mammoth Hospital, that those people are covered. So we're trying to make sure that that remains balanced, and that the access is there. Ultimately, we want everybody who wants vaccine to get vaccine. So I don't feel like there's a huge a disproportionate swing one way or the other, but definitely something we're continuing to communicate about.
Okay, thank you. Dan, do you have questions?
Yes, I do. I'd like to get a better understanding of how we as a county are getting our allocation of vaccines. I have not heard rumors. I've heard directly from two people. One, a 30-year-old with no other underlying conditions and no occupational health, who has been vaccinated in Mono County. And my baby brother, who is 73, has gotten vaccinated in LA County. Why is it that those two counties, are they just getting more vaccines per capita, or are they some not following the rules? What's going on? How do we get allocated, and how do you deal with the equitability?
So the allocation question, all counties are getting allocated based on population estimates for the current tier. So for Inyo County, for example, the state's looking at what our total population of 65 and over is, and our and then estimates of the industries that are covered within the current tier, and giving an allocation based on that. And that's what's happening statewide. I would say that we started out with a little bit more proportional vaccine allocated because of the large number of vaccine from Pfizer that comes per pack. So I would say probably at this point, we're proportionately, in some of our smaller counties, actually have more vaccine per capita than many of the larger counties. And I imagine at some point that's going to catch up, but just by fact of that we had to receive 975 vaccines right off the bat from the Pfizer allocation and split those between Inyo and Mono, we actually started off in a better position there. Now, to speak to how people are getting in and how they're prioritized, I do agree that every county is trying to be as consistent as possible. That is really important, because we don't want people finding that they can get it in one place where they can't get it in another. So there's constant communication, and to be quite honest, you know, as we're moving forward, that changes a little bit from day to day in some cases, as far as the guidance that comes down from the state, and also really depends on from a county a specific perspective, what providers are out there, how that communication's going, how those prioritizations are happening. And then There's the how people are registering and how much we can vet at point of vaccine distribution, and making sure that we're double checking and making sure that people aren't getting into that system when they getting in for those appointments when they shouldn't be. And we're doing the best that we can to safeguard against that and verify at the point of giving the vaccine, balancing that we're also trying to get as many people through as possible in those clinics. So I would say that in Inyo, I feel pretty confident that we've been very careful about that, especially because we have just some very key places that vaccine is being distributed right now. And really, ultimately, we'll be able to expand to a few more providers, but that network will remain fairly small in Inyo just by virtue of we don't have a whole lot of providers to distribute vaccine through. So I think we'll be able to keep a pretty good handle on that, but it's going to be logistically just very challenging. We'll I think continue to hear these stories of someone who got in who shouldn't have, and we're doing everything we can to prevent that, because we do want to make sure that the distribution is fair. But I don't think speak to those two specific issues, because I don't know exactly what happened in those two cases.
I can say that once the vial is opened, there's 6 hours to get the doses out. And I talked with friends who are providers, and if it's 4:45 and the bottle's open and there's 2 shots left in it, they're going to find whoever there is in the hallway to stick that in their arm rather than throw it away.
In LA, they actually have a line they form during the day at some of these vaccine places where it's called the leftover vaccine line. And you can go stand in line and wait, and you might get a vaccine by doing that. So I'll just say, Dan, of course there are anomalies in other counties. To me, that means that other counties aren't doing a very good job of distributing their vaccine fairly, and our county is, because we're not hearing that. So I get it that other places might, I mean, who knows how people are doing it, but I'm proud that we're not hearing those stories from here. And I mean, that to me seems ludicrous that LA County somehow is letting that happen, but I certainly am proud that that's not happening here.
Yeah, and I would say that.
And hearing how we're getting our allocation throughout the state is a very reasonable way to do it. And so that's very satisfying that if it's based on the number of people in each tier, that's a good equitable way to do it. And if a few people, because of the leftover vaccine, are getting vaccinated, that's great too. And it may look like an anomaly where it really isn't. And once again, yes, I'm proud of the way Inyo County is doing this by following the rules and making things happen right. So that clarified a lot of it for me. Thank you.
I'll just add that this vaccine, especially these 2 that we're working with right now, not only because they're a little more difficult to store and manage, and because they have this requirement that once one of the vials is punctured, it be used within 6 hours, has added quite a bit of complexity to making sure that 1, we're not wasting vaccine, and 2, we're managing. So, I mean, we are scrambling constantly. We're working very closely with the hospital. We have every day that we're doing a vaccine clinic, we have a long list of people who are in that same tier or above that are lined out and ready. And I tell you, I'm calling people when we're doing clinics here, and we're getting really good response. We just worked through this for a vial that needed to be used today at Northern Inyo for today, and are really helping to get those people in. But we are focusing on getting those people that are already in the current tier as our backup go-to call list, and that's worked really well for us.
Marilyn, you were chomping at the bit.
No, I was just, I was only going to add that, you know, for the public, that, you know, sometimes a job title does not necessarily fully I speak to risk and exposure issues. And so we want to be cautionary. We also live in communities where we have people who may work in a non-high risk area, but volunteer as emergency responders. So we, you know, for our public, I think it's important that we just, you know, when we hear those kind of anomalies, that there may be more to the story than we know. So, but I think we can reassure the public and your board that we are trying to distribute fairly and within the guidance and requirements given to us by the state. So.
Thank you. Are we ready to hear from Dr. Richardson now?
I have one more comment that Anna made to what Anna made, and that was that at the present time, we're not so much worried about having people that can give the vaccine, although we are. And I can tell you that at the EMCC meeting last night, that was one of the topics that they discussed. They're training up people to be able to give shots. We actually, and correct me if I'm wrong, Marilyn, but Chief Dell said that we actually sent 5 people down south that are qualified EMTs to give shots for 14 days because they had a lot of shots, but they needed people to give them. We're not in that position yet. I think we will be, and we're actually preparing for that. So I think there will be enough people to give the shots. I know that Joe Dell also said that they're training up, they're going to classes, they're sending people to classes, they're having classes to be able to give these shots when they're available, when the vaccine is available. So I think that was a positive note from my point. And the other thing I have to say is that, you know, the anomalies are going to be there no matter what. Sam Jones is going to get one before Sally Ann, and Sally Ann thinks that she should have got one. The bottom line is the more people that are vaccinated, the better it is. The less chance that the spread will take place with the more and more people that we can get vaccinated. So the anomalies, I think, are really not even an issue, although they will be emotionally. But I think the more people we can get vaccinated, the better it is, as soon as we can.
Okay, and I see someone has their hand raised, but I'd like to at least get through the medical part of this and let Dr. Richardson talk. And then before we see if Ms. Chapman has anything to say, we can take some public comment. So go ahead, Dr. Richardson.
Yes, good morning, supervisors. I want to praise the staff that's working on these vaccines allocation and distribution. It's been a very difficult task for all of them, and it probably is going to continue that way as long as the vaccine is short in supply. It's probably, even if we do get a load of vaccine, enough to vaccinate everybody we want to vaccinate, it's probably going to be up until May before we get everybody covered to at least a 70% rate. So one of the things that I've been concerned about, I've been watching these variants that have been cropping up, and maybe others have seen it in the news. The variants have an increase in infection rate, and that's a concern because it's a race between the virus mutating and our ability to vaccinate. I don't know if we're going to be able to vaccinate fast enough and carry out the numbers we need to slow this virus down. I hope we do, but it's a concern. The pace between the mutation and the vaccination is going to be a big issue. The virus is already getting more infectious, up to 30 to 70% more infectious. And that means that the virus is going to infect more people, cause more sick people, put a strain on the hospitals and healthcare workers, and increasing the death rate. One of the concerns I have is that the more people that get infected, and if this virus continues to mutate and become more transmissible and infectious, we're going to have more cases, and the ability for the virus to mutate to a point where our vaccines are not effective. That's a big concern. The more people that have the disease, the more likely the vaccine can mutate. So what do we do in the meantime until we get people vaccinated? We have to go back and do what we know to prevent infections. And that's the big issue is right now, they point out that, for example, with a 50% rise in infectiousness, and right now it's between 30 and 70%, in 2 weeks, you get twice the number of cases. And in 1 month, it's 4 to 5 times as many cases. And that's all due to mostly gathering. The more you gather, the more infections you're going to have. If you stay away from people, you won't get infected. And this is a very hard concept right now because people are doing what they want and ignoring some of the basic guidelines, and which are avoid optional gatherings with other people. That's going to be extremely important until we get everybody vaccinated. The odds of becoming infected rise the longer you're exposed to these individuals in a group. The bigger the group, the more likely somebody's going to be infected in that group. The other issue is the virus that is mutating and more infectious. There's a good chance it has a higher viral load. So when an individual has this new mutated, highly infectious virus, they could be spewing out more viral particles and infecting more people with the same not resistant, but strain that has increased infectivity. So the best protection still remains avoiding contact with other people indoors. Indoors is a big issue. Avoidance has been shown to substantially lower transmission compared to indoor activity. So outdoor is the place to be. And there has been evidence through contact tracing studies that suggest the transmission risk is 20 times higher in indoor setting compared with outdoor environments. The risk is not zero, but it's significantly lower than being indoors. And the other issue that's come up recently, and I've always wondered about this, is masks. You notice there are so many masks on the market. It becomes sort of trendy to have a type of mask, and you don't know how they're made. And there's a concern now coming down from the experts about the types of masks, especially the cloth masks. They're often not worn appropriately. They are less effective than a surgical mask. The surgical masks are much more effective than the cloth mask, especially if they're not worn properly. If you have a surgical mask that is fitted properly, meaning over your nose and mouth, tightly worn, the transmission rate of the virus is cut down significantly. The masks are not 100% effective, but if you stay away from people, that's 100% effective. So if you're wearing a mask when you need to and avoiding gatherings and using a mask when you do come in contact with people and limit that time, your risk for catching the disease, especially these new variants that are highly infectious, decreases rapidly. So I think in the future, near future, we may have to address the mask issue. The masks seem to be less effective now, the way people wear them. I think the education of the public, the CDC has been behind on the use that they recommend cloth masks. I think the cloth masks are coming to an end here soon because of the nature of them. They lack the ability to prevent transmission and they're not effective. Now the latest news I heard is wearing 2 masks. In other words, 2 surgical masks are probably more important in these times when these 3 variants are running around, one from Brazil, United Kingdom, and one from South Africa. So it's something to think about. I've been looking into the future on what's going to happen until we get everybody vaccinated, and it's going to be a logistical challenge to provide all the vaccines we need, even in our small county. And our staff is working so hard, and providing such a good service that, you know, it hopefully will come to pass where we'll have enough vaccine. That's going to depend on the feds and our state. We just aren't getting the vaccine, according to Anna. I'm not sure what the future holds, but hopefully we'll get more. That's what I have to add this morning.
Okay, thank you. I know that some board members have some questions, and go ahead, Matt.
Yeah, I have a couple of comments and questions. One, we had a public commenter who talked about religious services. Could one of you address whether religious services are being are actually spreading the virus? Is that something that we're finding? I know I get it that you maybe can't go into specifics, but I'd like to hear that. The same commenter also said that we had the highest rate per 100,000. I don't know if she meant in all the United States or California. At 90 per 100,000, I looked and I think California's rate, average rate is actually 95 per 100,000. And if we're at 90, then we're actually below the average. For a mass vaccination to happen, is the only way that's going to happen if another county doesn't use all of their allocation and we get it reallocated? Is there it? So in other words, is that because counties are actually probably getting better at using their allocation as we go along here. So I would think that the chances are going to decrease that other counties will have leftover vaccination to put back into the system. When Dr. Richardson, when you talk, when you say surgical mask, that's the blue mask, not necessarily the N95 mask, right?
Well,
and those are all my questions.
When I talk about masks, the cloth masks are very popular. You see lots of them, and they have different types, colors, and whatnot. If they're made properly, they are probably effective. The problem is you don't know how they're made and what material and how much layering they have. Now, when I talk about masks that are surgical masks, they're blue on the outside and white on the inside, and they have to be made by a reputable company. Now, the N95, so the surgical masks are better than the cloth masks. The N95 is better than the surgical mask.
Okay.
Now, I don't know if they've done any comparison if you're wearing a double surgical mask compared to an N95, but I imagine the N95 is still superior to the surgical mask.
Good. That clears that up. I just wanted to make sure I knew which surgical mask, or what the definition of that was. And
it's when you see pictures of a surgeon operating in the operating room, they have that type of mask on. That's why they call it a surgical mask.
Right. Right.
And Supervisor Kingsley, to speak to the first question, and Dr. Richardson can add to this. When we do case investigations and contact tracing, we're not necessarily, sometimes we're able to find out that there was a attendance at a gathering. That oftentimes is what we're finding out. But the purpose is not to find exactly where that transmission occurred at. It's really about contacting and getting people isolated or quarantined as appropriate. However, on some of the indoor activities, and whether or not transmission happens or is associated with specific types of activities such as religious ceremonies, that the decision at the state level and the guidance and scientific reasoning is about risk factors. And whether you're indoors in a ceremony or you're indoors with a group of people for any reason for an extended period of time, you sometimes may not have ventilation that's appropriate. If you're mixing households, not using face coverings, it increases risk, especially if within the context of that grouping of people, for whatever reason, if there is someone who is COVID positive and asymptomatic, they are, the risk for transmission is increased. And so the reasoning is not, I don't know that we have a good answer as to what percentage of cases could be directly connected to attendance at a certain type of event or activity. We have much more anecdotal, probably, that as we've done contact tracing and case investigations locally, that gatherings indoors have been a primary factor. Dr. Richardson, is there anything you wanted to add to that?
No, I think you've stated that quite well. If you look at the data that's collected, and this virus is one that we're learning all the time about, but the contact tracing studies, for similar to what Marilyn is talking about, has shown that the risk for transmission goes up 20% higher in indoor settings. So you have to factor that into your decision making, and I imagine that's what the state has done in terms of indoor activities. Now, has a certain number of cases come out of the certain sectors that application gets adjusted to? That I don't know, but what they're trying to do is limit the possibility of an outbreak from those facilities. It's just like the Bishop Care Center that we had an issue. We did well. We kept everybody out of there that were ill and possibly infectious, but then all of a sudden there was a breakdown in the system and we had a high population of deaths in the Bishop Care Center. So just because something hasn't happened, that doesn't mean it's not going to happen, especially in a high-risk situation. You tend to try to avoid the high-risk situation to prevent what could happen. But then on the flip side, somebody makes the argument, well, you never see anything happen in there, but that doesn't mean it's not going to happen the next day.
I totally get that, and I think, thanks for answering that. I do think, gatherings clearly are the issue, and I just was asking if there was, there was, a statement made that religious services were maybe, I think she even used the word super spreader, and I just wondered if that is something that we have evidence of. I am not advocating to, I think everybody needs to understand what we're saying here is that indoor activities with, especially unmasked and well, just it increases the chance of spreading the virus, and not advocating one way or another. Just wanted to double check that. And then also I did want to see if somebody could address the 90 per 100,000 that is our county. Anna, you got that? You have that information?
Yeah. Pulled up all of the data for the state for last week, which is still what's being reported out on the state website. And so Inyo County is at a little over 90 cases per 100,000. At the statewide level, we're reporting 105.4 positive cases per 100,000 overall within the state. So we're close to the statewide level. Definitely one of the higher case rates in the state. As we've seen in the past, statewide, we're starting to see a decrease in those overall case rates, and new positive cases popping up on a daily basis. Really quite a marked trend in a downward direction around that over the last week or so. So what we've seen in the past is that typically Inyo Inyo kind of lags behind some, especially some of the more urban areas. So we're still kind of at the plateau of our case rate, and we're really hoping to start to see that downward trend as well, and to match the state. But those numbers are accurate for that were posted last week. We will see an update later today. Typically the blueprint tier assignments get made around noon each Tuesday. So we'll see the updated numbers for Inyo County posted a little bit later today.
Great, thanks. I just wanted to, let me finish, Dan. I still got one more question that they're going to answer. I just wanted to confirm whether we were the worst in the country or not. I mean, or the state, and it doesn't seem like that. I'm not happy with 90 per 100,000. I want to make sure that that's clear, but I do think for the public to know how bad it really is in comparison to other places is important. And then the last question was about the mass vaccination. Is the only way that we would get that if another county does not use their total amount?
Right now, we do have the opportunity each week to request additional vaccine. And at this point, that would be redistributed vaccine that's not being used effectively. So the state's putting in some new, and we expect actually more changes forthcoming in how to manage that statewide allocation and supply. So right now, each Tuesday we get our allocation of what vaccine we're getting for the following week. We have an opportunity to request more. So we have routinely been requesting more vaccine because we do want to be able to get that larger amount to be able to do a mass vaccination clinic. Two things can happen in the meantime. One, we just generally get more vaccine. And what I'm hearing right now is that based on the vaccines that are currently have FDA approval, we're not expecting a huge increase in the overall availability of vaccine in the next few weeks. Where we will see a larger increase in the supply will be when we have additional vaccines come onto the market. So right now, we're not expecting that we'll magically get double or triple the allocation over the next couple of weeks. So we are continuing to ask for that redistributed vaccine. So far, we haven't got what we've requested, but we are hoping that as the state is continuing to look at ways to manage that and redistribute more efficiently, that supply may be moved between counties a little bit easier.
Okay, thanks. I just wanted to make sure that as we're talking about the mass vaccinations, that it's how that can happen. It seems like until we get another vaccine approved, that may be tough for us here. I would just think that counties are going to get better and better at using all their vaccine and not.
Yes, I would say that everybody has ramped up and is pushing it out as quickly as possible. So it.
Thanks for answering all those questions. Thank you.
Okay, and if it's okay with everyone, I had promised Shayla Ann that she could have her comment after Dr. Richardson. So if we could promote Shayla Ann.
Hi, it's not Shayla Ann. My name's Ken. I'm Shayla Ann's husband. And I have two questions. I wanted to ask, maybe Anna can answer this. Has there been a super spreader event in Inyo County besides the care center? Have we identified like an incidence where we can really drill down and see that a lot of infections happened at a certain place at a certain time somewhere in Inyo County?
Yeah, I would say that the care center event was the largest outbreak. Though we have had some other outbreaks that we've followed that were either workplace based or gathering based on a smaller scale. And I don't think I actually can give a lot more detail around that, but we have had some other smaller outbreaks that have been followed by the public health nursing staff.
So could you give numbers though? I mean, we know the care center numbers, but these smaller outbreaks or these smaller, less than super spreading events, do you have numbers for those? Can you say those numbers?
this would be off the cuff and estimated, but I would say that in general, the other outbreaks or clusters that we've seen have probably been in the dozens, low dozens, 10 to 20 people max.
So in one
most of
event,
them are
we've
much
been able
smaller.
to, in one event, we've been able to identify a dozen infections. Wow. Okay. I just wanted to get that out, that this was a real thing. I also wanted to ask the doctor a question. The mutations that you spoke of, do we know that these mutations have mutated beyond the bounds of the vaccine's ability to stop it? Or
No.
is that just a prediction?
Well, the current, that was always a concern. They're doing genetic sequencing constantly on the viruses to determine whether or not they've mutated to an extent that they can escape the vaccine effectiveness, and also to look at what the variants are like in terms of transmissibility. I spoke to the transmissibility. It's increased significantly in these new strains that are popping up. But according to the epidemiologists at large centers, the vaccine that we have now, the Moderna and the Pfizer, are both effective against these current variants that are highly transmissible. The problem is trying to keep up with them, meaning vaccinating the people so we chase down these variants before they multiply into a different variant.
So we have a mutation rate roughly, and we have the boundaries that the vaccine within which the vaccine works, right?
I don't understand what you mean by boundaries.
So we have a mutation rate. We understand how fast the virus mutates or how often it mutates.
Well, I don't have an answer to that specific question. We do know that within, I think it was in early December, the United Kingdom had the mutation that was considered more infectious and more transmissible. And since then, we've developed, or they've seen with genetic sequencing, a South African viral variant, and also the most current one is the Brazil variant.
Okay, and the difference is not that it escapes the vaccine. The difference is its transmissibility. Its infection rate would be greater.
Yeah, currently that's the thinking. They just have increased from 30 to 70% more transmissibility.
Okay, and we know what our vaccination rate is in Inyo County, and we know the infection rate, although obviously both these things change, with availability of the vaccine and how fast or slow people get infected. But we can actually, if we know those things, we can really give some hope. Isn't that true? I mean, if the virus is still susceptible to the vaccine and we have a vaccine rate going on, we know how fast vaccines are happening. There's some real hope that we're going to vaccinate people before the virus can mutate outside the boundaries of this vaccine. And this looks good in my mind. I just seemed like I heard a whole bunch of really sad news, and I wanted to see if there was some possible way we could put a positive spin on some things. I think if I can make this comment, I think people respond to hope a little better than they respond to grimness. And if the real goal is to get compliance with the policies, I think compliance would happen a lot easier with a hopeful message than with a comply or we're all going to die kind of message. I mean, that's my suggestion. I throw that out there. I know I asked questions and I made a suggestion, so I'll put my hand down.
Okay, thank you. Appreciate the comment. And definitely there is hope. This is a dangerous period, but that's a good segue into my comment and question.
I grilled him, like I was
and that is, I do have, I'm happy that the regional stay-at-home order has been lifted, but I do have some fear with this, in that the messaging from the state has been pretty confusing, and that the public is going to take this as a, message that they can, go out and party. And I think this is not the time to party, obviously. And so I was talking with a friend this morning who brought up something I didn't even think about, but the Super Bowl surge. Super Bowl's coming up. Lots of people like to gather for that. Now is not the time to have a Super Bowl party. And hopefully the public can understand the real danger of that happening. And those would typically happen indoors. And I want to get a clarification on something that you said, Dr. Richardson. You said indoor activities. I think at one point you said they were 20 times more likely to spread the virus, and another time you said 20% more likely. Did you mean 20 times?
20 times higher in indoor settings.
Okay, that's what I thought. I just wanted to clarify that. Thank you.
Now, this is a suggestion by contact tracing studies. They went back and looked at the contact tracing, not just in our county, but overall, and they came up with a higher rate in the indoor activities.
Yeah, understood. But yeah, I guess the message I think we really need to get to the public is, I made an appointment to get my hair cut. Like it's really good that we can have these sorts of activities happen as safely as we can, but it is not open season to do risky activities. And it's still extremely important that, we've got maybe 10% of our population vaccinated, maybe another 10% that's had the disease already. So, rough numbers, we're at 20%. We need to get to 70 or 80% in order to have any sort of herd immunity. We have dangerous new mutations that are more infectious and more deadly that are certainly in Los Angeles, maybe here as well, that now is still the time to be as safe as possible. Leslie, did you have anything to add into the report?
I do have a couple things to add. Thank you. Good morning, everyone. I just wanted to go back to the idea that the regional stay-at-home order was lifted yesterday morning. That was really great news for the businesses. I'm really impressed with our team and how quickly we were able to get the word out. Our public information officer, Karma Roper, got the press release out right away yesterday morning, and then we were able to follow up with emails to all of the businesses that we have contact information for. And then I was able to spend quite a bit of time on the phone yesterday talking to businesses, and the feedback that I'm really getting is that they're very committed to safety. They thoroughly understand that if they're able to conduct their businesses safely, then the odds of being able to stay open are much greater. And I feel a commitment to that. And so that was really a positive spin that maybe has been a little bit different than when we have had to go backwards in the past. So I'm really hopeful that people get it and they will, mask and have their customers mask and distance and all that stuff so we can get through this without another shutdown. Other than that, I just wanted to remind everyone that Friday at 5 o'clock is the deadline for the nonprofit grant applications. They're slowly starting to trickle in, but I have to say that I would have expected that we would have more by now. So hopefully everybody's getting those together and getting ready to submit them. We do have an email that's going out today to all the nonprofits that we have contact information for. There will also be a posting on Facebook, the county Facebook page. And so I just ask anyone who happens to see that to grab it and share it with all of your contacts. because we admittedly don't have as good of a list of contact information for nonprofits as we do for businesses. So we can use all the help we can get getting the word out, and we hope to see a whole bunch of applications on Friday. And unless you have any questions, that's all I have.
I have a question or a comment on that, Leslie. So I have heard from some nonprofits that are hesitating to apply because they think surely there must be other nonprofits that are more effective than them. And what I'm telling folks is to apply, and you can always, if you feel like there's some other nonprofit that didn't get an award that would deserve it more, you could always decline the award in the end. I don't know, do you think that's good advice that I'm giving folks, or what's your comment on that?
I don't know how to comment on that. I think that if you're a nonprofit and you've had a loss and it's impacted your operations and the loss is due to the impacts of COVID, then that's the requirement, apply. And we tried to keep the rules fairly loose. We weren't bound by the same criteria that we would have if it was CARES Act funding. I remind people this was a county board of supervisors decision to allocate the money. And so, it's not as strict as even the Revive grant. And so, anybody that suffered a loss and it's impacting operations is eligible. And I have no judgment about who might be more deserving than others. And I don't think our committee does either. I think that's going to flesh itself out through the review of the applications. So my advice is just like yours, Supervisor Griffiths. If you've had a loss, apply.
I just have a comment on, I think Marilyn and Anna, I want to thank you for what you are doing, and of course, Dr. Richardson and the whole team. But on the other hand, I also want to thank you for your definition of risk. I don't know how many people I've talked to, a lot of people who said, this should be an individual decision. It's my life, so I should be able to do what I think I want to do or should do. But I think that risk definition goes a lot wider, and I think you brought that up. That you're not only sort of monitoring whether there's a risk to you, but also a risk to others. And I think that's the most difficult thing. I don't know how many people I have 80-year-olds that say, I don't care. I'm not going to wear a mask. I don't, I don't care about myself. But the bottom line is, when you take that risk, you also take that risk for a lot of other people. When you go to the grocery store, or when you leave whatever event you're at. So you're risking a much broader part of society than just your own, because it's pretty easy to make that decision for yourself. But I don't think it's that easy to make that decision for others. So thank you for that definition. I think that was really important, at least to me.
Okay, thank you, Rick. Is there any other comments before we move on to the next item? Oh, we have a couple of hands raised. Joshua Nicholson was first. Could we please promote him?
Good morning, board. Thanks again for not only talking to me, but the public. I guess keep it short today. Couple of questions, mainly for Dr. Richardson. One, I was just kind of curious about, all the numbers that you had spoken about earlier, where those are coming from. And then just to refer a little bit back to a little bit of what I spoke about last week, I still haven't heard our health officials talking about preventative measures outside of the mask and social distancing. And I wasn't able to get on this morning to hear whoever was speaking about the super spreader events. And again, I'd ask that person and every person, what are you doing for yourself? What are you doing for your nutrition, spiritual health, mental health, and those things. But again, going back to my question, Dr. Richardson, where are you getting your numbers, sir?
Is that the only question you want answered, or the other two comments? So the only question is, where is the data coming from?
Yeah, I mean, those are, yeah, the other two are mainly statements. I mean, I guess I may have some additional questions.
Well, the answer,
So hold on, Dr. Richardson. So Josh, if you could get all of your questions out at the beginning, I think that would make this go smoother, and then the staff can write them down and answer them for you.
Okay, my apologies. I guess for now that'll be it.
okay, in regards to the sources of my information, I acquire them from various sources, but much of what I quoted today in terms of numbers and studies came from Harvard epidemiologist Mark Lipstick. And one of the others that I admire greatly is the ex-CDC. He was the head of the CDC until this current one is, and that's Dr. Frieden. If you ever listen to him talk, he is so logical and straightforward on the issues. He's very good. So those are the two main ones I have acquired much of my information from today and in the past.
Thank you, Dr. Richardson. Okay, I also see that Lynn Greer has her hand named. If we could promote Lynn.
Can you hear me?
We can. Good morning.
Hi, good morning. I too am really excited that my friends get to go back to work. And I think as business owners, all of us have worked really, really hard to do our part in keeping our businesses clean and trying to babysit the public who want to argue with you about a mask. I mean, it's just been a really, really difficult situation. And the county as well. And I have to commend Anna because, you know, I mean, I've known her since she was a baby, and she's answering these really tough questions that she really probably doesn't have the answer to at no fault of her own. So I know that there's people that are mad and there's a call for unity, and I just want to have, you know, just a greater understanding when people watch these board meetings and they realize what you guys are really up against when we as public citizens don't feel we're being heard or our needs are being met. And all you have to do is turn on the news and you can see what a disaster it is nationwide. And, you know, I have no blame for anybody because this is so massive, but I just think that in Inyo County, as far as our employees go representing us, I think that we're really lucky. So great job, Anna.
Yay, I think we can all say great job, Anna. Okay, wonderful. Let's see. I don't see any other hands raised. Darcy, do we have any other public comment on this item?
No, Mr. Chair.
Okay. Thank you everyone for your patience and your hard work on this.